Hey, how's it going, everybody? Welcome back to another episode of Pathagonia. So tomorrow I'm presenting 7 cases at Chest Tumor Board, and the majority of them are lung cancers. Actually, all of them are lung cancers, but they vary between adenocarcinoma, squamous cell carcinoma, and some neuroendocrine tumors. And conveniently, there's a Kurtz Notes PDF that goes over lung tumors. It goes into far more detail than I'm going to cover in this video, but I am going to go over the first few pages that cover some of the entities that I'm going to be presenting tomorrow. And again, this is largely just a review for myself. I'm not a lung expert at all. I actually haven't seen a lot of lung on my surgical pathology rotations, but I figure the more time I spend reviewing these notes, the better prepared I'll be tomorrow, and ultimately we'll get better patient care, right? If we're more prepared and able to do our job better as pathologists. So let's just go ahead and get started. So first up, we've got adenocarcinoma. So we're familiar with adenocarcinoma as being a malignant epithelial tumor with glandular differentiation, mucin production, or pneumocyte marker expression. So lung cancer, including other carcinoma types, is the most common cause of cancer death worldwide. Obviously, there's a strong association with tobacco smoking and other risk factors like radon, air pollution, and occupational exposures. The symptoms of lung cancer may vary depending on the sites of involvement and include chest pain and hemoptysis, so coughing up blood. However, most patients present late with advanced or metastatic disease that is inoperable, unfortunately. So on CT, they're often peripheral, adenocarcinomas are, with solid invasive areas and ground glass lipidic areas. And the histologic patterns may vary of adenocarcinoma, and there's use for non-mucinous adenocarcinomas. If an adenocarcinoma subtype or architectural pattern is identified on biopsy, it should be reported. Report in 5% increments and classify based on the predominant pattern. So some of these histologic patterns or subtypes that we talked about are listed here in this table. So we have lipidic, acinar, papillary, micropapillary, and solid. And let's just go through them. So with lipidic adenocarcinoma, you're going to see growing along the surface of alveolar walls like AIS, and it's non-invasive. So we're seeing that here, right? Almost looks to be hobnailed along those alveolar walls. With acinar, you're going to have round to oval glands with a central lumen space surrounded by tumor cells. Papillary, you're going to have glands growing around central fibrovascular cores, which we're familiar with other aspects of pathology. Things that are papillary often involve fibrovascular cores. And if we lack fibrovascular cores, that's going to be micropapillary. And again, this isn't just in the lung. This occurs elsewhere throughout the body pathologically. You can also have a solid type of adenocarcinoma with polygonal tumor cells growing in sheets, which is what we see here. So if exclusively lipidic on biopsy, report as adenocarcinoma lipidic pattern or something similar. On resection, this could represent adenocarcinoma in situ, minimally invasive adenocarcinoma, or simply a lipidic component of an invasive adenocarcinoma. So radiographic correlation is required preoperatively. And criteria for invasion in a lung adenocarcinoma is 1. Histologic subtype other than lipidic, such as acinar. 2. Desmoplastic stroma associated with tumor, and desmoplastic response is something that we commonly see in malignant processes, right? 3. Vascular or pleural invasion, and 4. Spread through air spaces, or STAS. So IHC for lung adenocarcinoma, it's going to be positive for TTF1, napsin A, and CK7. So at our institution, or my institution that I train at, as well as Dr. Wong, my colleague and co-founder of Pathagonia, we have a dual stain of TTF1 and napsin that can often be used if we're trying to determine if it's an adenocarcinoma or a squamous cell carcinoma. Welcome back, everybody. So I just wanted to quickly go through Pathology Outlines page for lung adenocarcinoma, and thank you to the authors, Dr. Underwood, Alexis Music, and Dr. Glass. So I'm sure you're all well aware of Pathology Outlines by now if you are a pathology resident like me, or even if you're remotely interested in the field of pathology. It's an incredibly useful resource. So I'm just going to run through some of the highlights of lung adenocarcinoma, and a lot of it will be repetition from Kurt's notes, but as we all know, repetition is the father of learning, so you just have to keep going over things, at least for me, until they stick, right? So adenocarcinoma, or non-small cell lung carcinoma with glandular differentiation, often has mucin production or pneumocyte marker expression. And adeno is the most prevalent non-small cell lung carcinoma with those 5 main histologic patterns. So acinar, papillary, micropapillary, lipidic, and solid. And you can also have mucinous and non-mucinous subtypes. Adenocarcinoma is positive for TTF1, which is going to be an important IHC to differentiate. And then sites, just to point out, more commonly located peripherally rather than centrally. And then I did want to just show a gross image to highlight that peripheral location. So we have a gross image of the lung here, or a section through the lung. And we can see that the tumor here, where the arrow is pointing, courtesy of Utah University, their medical school, I believe. You see the tumor is peripherally located, and this is in fact an adenocarcinoma. And the solitary appearance of this tumor suggests that the tumor is primary rather than metastatic, right? Because if we had a metastatic process, we may imagine seeing multiple small lesions. I guess you could still, of course, just have one, but the fact that it is one probably suggests that it's more likely a primary lung process. And then the only thing else I wanted to show, I did want to show some cytology for lung adenocarcinoma. So in D here on the bottom right, sorry, my dog is sneezing in the background. We see cytology from different adenocarcinoma shows large malignant cells with abundant cytoplasm and prominent nuclei growing in an acinar structure. And you can really appreciate that here. So you have these prominent large pleomorphic nuclei with prominent nucleoli, and you can see that they're growing in acinar structures. And this is a cytological sample of lung adenocarcinoma. And just a quick review of the IHC, and then we'll be done. So lung adenocarcinoma is going to be positive for TTF1 and napsin A, as well as CK7, AE1, AE3, and beta-catenin. And it's going to be negative for P40, P63, and a host of other stains. All right, next up we've got squamous cell carcinoma of the lung. So squamous cell carcinoma, or SCC, is a malignant epithelial tumor that shows either keratinization, intercellular bridges, or expresses immunohistochemical markers of squamous differentiation. So here, the arrow, we can see some of that keratinization, or on histology, you might see orangiophilia or orangophilic processes. So squamous cell carcinoma is strongly associated with smoking, and it's often centrally located, unlike adenocarcinoma, which was peripherally located. And it may be keratinizing or non-keratinizing. So the IHC for squamous cell carcinoma, it's going to be positive for P40, P63, and CK56, and then negative for TTF1 and napsin A. So remember, for that age-old debate of is this an adenocarcinoma or a squamous cell carcinoma, IHC can be really useful here. TTF1 napsin favoring adenocarcinoma, and P40, P63, or CK56 favoring squamous cell carcinoma. And you can also have a basaloid squamous cell carcinoma, which is a proliferation of small with high end-to-C ratios, distinct borders, cells with lobular architecture and peripheral palisading. There's no nuclear molding, and there's a lack of overt squamous morphology, but express squamous IHC markers. So you're going to see lots of mitoses and often hyaline or mucoid stroma, and most compose about above 50% of the tumor. So on IHC, it's going to stain with some squamous markers, and the Ki67 is often 50 to 80%, with only focal neuroendocrine marker staining. And basaloid squamous cell carcinoma actually has a worse prognosis than squamous cell carcinoma otherwise. All right, so again, I'm going to go to pathology outlines for squamous cell carcinoma of the lung. And thank you to the authors for this page. So thank you to Dr. McGow and Dr. Sharma. And my apologies for any mispronunciations. So squamous cell carcinoma of the lung is a malignant tumor arising from epithelial cells with squamous differentiation, demonstrated either immunohistochemically or morphologically with the presence of keratinization or intercellular bridges. And it can be keratinizing or non-keratinizing, and subtypes include solid, cystic, papillary, pseudoglandular, alveolar filling, and sarcomatoid or spindle cell change. And the essential features for squamous cell carcinoma of the lung are morphologically identified with keratinization, keratin pearls, and intercellular bridges. With poorly differentiated lesions, they may lose morphologic features of squamous differentiation and require IHC to separate from other non-small lesions. P40 positivity will help, as we previously discussed. And primary and metastatic tumors have an overlapping morphology and immunohistochemical profile. In most cases, it is not possible to determine the primary site of a squamous cell carcinoma. All right, so moving on, I just wanted to briefly touch on the cytological description, as I am on cytology this month. So cytologically, what are we going to see in a squamous cell carcinoma? Well, we can see atypical cells with keratinization seen in well-differentiated cases, and higher grade lesions may have similar cytologic appearance to adenocarcinoma, of course, which IHC studies are going to help us to differentiate that on the cell block. And on cytology, it often demonstrates stretching of the cytoplasm, referred to as tadpole cells. So let's just take a look at that atypical keratinization. So on the left here in A, you see a keratinized cell, and on the right, you would see a tadpole cell. And if anyone's ever seen a tadpole in the wild or in the world, in life, you know that they look a lot like that. They have elongated tail with their head in this area. So if you see this, atypical keratinocytes or keratinized cells, and then tadpole cells, this could be features potentially of a squamous cell carcinoma of the lung. And a quick review of the IHC. So squamous cells are going to be positive for P40 and P63, strongly and diffusely positive, and are more specific for squamous differentiation. However, P63 is less specific, so P40 is preferred. Other stains that could be positive are CK7, high molecular weight keratins, pan-keratins, and CK56. And then PDL1 expression is variable and scored using tumor proportion score. And then again, importantly, negative stains are going to be negative for neuroendocrine markers, which could be used for like a small cell carcinoma or a neuroendocrine tumor, and then negative for TTF1 and CK20. So that's it. Quick review of squamous cell carcinoma. All right, just to close out our whirlwind tour of lung tumors, I'm just going to go over briefly neuroendocrine tumors. So neuroendocrine tumors have, unsurprisingly, IHC markers of neuroendocrine differentiation, such as synaptophysin, chromogranin, and INSM1. Less so CD56 or neuron-specific enolase, NSE. And cytokeratins often show perinuclear dot-like staining. So of note, lung neuroendocrine neoplasms are graded based on mitoses and necrosis, counted in a hotspot of a malignancy. And the Ki67 may be helpful to confirm your morphologic impression, but it is not currently used for grading. So neuroendocrine tumors in the lung, just like neuroendocrine tumors elsewhere in the body, are often evaluated based on their mitoses, rate of proliferation, and necrosis. So I am going to go over all of the entities just in this table, but I'm going to skip over some of the other entities, and be sure to review Kurt's notes on your own. Excellent resource, of course. So we're just going to talk, I'm not going to read the table, but I will note that we have a typical carcinoid, atypical carcinoid, large cell neuroendocrine carcinoma, and small cell carcinoma. So note that the way I think about it, and this could be wrong because I'm only a second-year resident, but I think about carcinoid as being a much lower grade. So in other areas of the body, you can have neuroendocrine tumors, which are less worrisome, and then you can have neuroendocrine carcinomas, right? So if we look at the Ki-67 proliferation index, which looks at the rate of mitoses or how rapidly something is proliferating or dividing, once you get into that 40 to 80% or almost 100%, that's when you're dealing with carcinomas, right? But these lower Ki-67 expressions, those are carcinoids. So I guess in my head, I bucket them as, well, as it says down here, right? A lower grade malignancy than an outright carcinoma. So just a overgeneralization, big picture, high altitude flyby, but obviously dive into the deeper aspects of this table. You can look into the mitotic rate specifically. So 2 to 10 is going to be atypical carcinoid, 0 to 1 typical carcinoid, and then over 10 is whenever you're going to get into your large cell neuroendocrine carcinoma or small cell carcinoma. So for a typical carcinoid, as I mentioned, it's a low-grade malignancy, and it often arises near the central airway, and it can grow in the airway, but occasionally can be peripheral and often has a spindled morphology. And tumor syndromes are rare. So, like many carcinoid morphologies or neuroendocrine processes, you're going to have organoid or trabecular growth, uniform polygonal cells with finely granular salt and pepper chromatin. So that salt and pepper chromatin is really classic for neuroendocrine malignancies. And you're going to have inconspicuous nucleoli and abundant eosinophilic cytoplasm. So a typical carcinoid, as I mentioned above, is going to have less than 2 mitoses per 2 millimeters squared. It's going to lack necrosis, and it's going to be more than a half centimeter. If it's less than a half centimeter, it is designated as a tumorlet. And then on cytology, you're going to have discohesive cells with stippled chromatin. So really for neuroendocrine processes, assessing the chromatin is going to be key, and seeing that stippling or salt and pepper appearance can help clue you in that you could be dealing with the neuroendocrine process and help you get those markers, right, like chromogranin, synaptophysin, INSM1. So atypical carcinoid, as the name would suggest, is slightly more atypical than the typical one. It's an intermediate grade malignancy and a tumor with carcinoid morphology and 2 to 10 mitoses per 2 millimeters squared, and or necrosis, often punctate. And this is, as you would expect, more mitoses, a higher proliferation rate, and a worse prognosis for the patient. So again, review these notes on your own, but I want to just skip to small cell and large cell. So small cell carcinoma is often centrally located in the major airways in the hilar region, and it often presents with rapid growth, metastases, including bulky mediastinal lymphadenopathy and perineoplastic syndromes, such as hyponatremia, Cushing's, etc. So small cell carcinoma has the strongest association with heavy smoking of all lung cancers. So you're going to have a small cell size, usually smaller than 3 resting lymphocytes, scant cytoplasm, which is what's going to make those cells appear so small, is because there's so much nucleus and not a lot of cytoplasm. You're going to have unclear borders with frequent nuclear molding, which is demonstrated well here in this image on the left. The molding of the nuclei and the cells into one another. You can have densely cellular sheet-like growth in the cells fusiform to round with finely granular chromatin, no nucleoli, and a very high mitotic rate. So more than 10 mitoses per 2 millimeters squared, median of 80, frequent necrosis and apoptoses. Ki67 is often essentially 100%. So a highly proliferative, highly mitotic process. And small cell carcinoma can be combined with other tumors such as squamous cell carcinoma and has a very poor prognosis. And here's some images on the right of what you might see cytologically in a small cell carcinoma. And to me, it's kind of ironic, but because the cells actually look kind of big. And that is due to, again, as we discussed, the appearance of the cell size is due to the high nuclear to cytoplasmic ratio. So there's not a lot of cytoplasm and there's a lot of nucleus. So in large cell neuroendocrine carcinoma, it's often going to be smoking related, often peripheral, and it's going to have a neuroendocrine morphology. Architecturally, you're going to have organoid nesting, palisading rosettes and trabeculae, and the cytological features of non-small cell carcinoma. So you're going to have large cell size, as the name would suggest, right? Large cell neuroendocrine carcinoma, large cell size, vesicular, coarse, or fine chromatin, frequent prominent nucleoli, and abundant cytoplasm with a low nuclear to cytoplasmic ratio. And again, you're going to have a high mitotic rate, more than 10 mitoses per 2 millimeters squared, and necrosis. And again, you can have combined large cell with other types of lung carcinoma, such as squamous cell carcinoma. And these are very aggressive processes.